So today we have a third lecture on surgery subject. So the title is The General Characteristics of Inflammatory Diseases, Dental Maxillo-Facial System and Maxillo-Facial Region. And also we're going to talk about surgical methods of periodontitis treatment. According to the latest statistics, over the past 20 years, the number of patients with various types of inflammatory processes of the maxillofacial region has increased by 16%. So, what are the reasons for that? We have a few of them. Of course, there's a much more, but generally, we could stop on few of them. So first one is late seeking medical attention. That is a problem because the people not loving doctors, as we all know, right? Then medical errors made during therapeutic treatment. Of course, it's iatrogenic things, yes. And we have late diagnosis of diseases. We have complications and incorrect treatment tactics, and also change in the species composition of pathogens and decrease in the reactivity of the patient's body. So, what is inflammation? As we all know, inflammation is a typical pathological process that occurs as a result of tissue damage and is manifested by a complex of structural, functional, and metabolic disorders, as well as microcirculatory disorders. So, as you remember, we have some clinical manifestation of the inflammation consists of local and general things. If we talk about local things, we have 5 signs, right? Tumor, rubor, calor, dolor, functionalesa in Latin. And all 5 things we have, all 5 signs we have in every inflammation. No matter it is a periodontium or it is, I don't know, kidney or something else. It's all the same. So let's talk about each of them. So we have redness as a rubor in Latin is a manifestation of local circulatory disorders in force of inflammation. At the stage of anterior hyperemia, the tissue acquires a bright red color, and later, due to transition of anterior hyperemia into venous, we have so-called cyanotic color. Then a local heat or calor in Latin is associated with arterial hyperemia, right? And intensity of catabolic processes in inflamed tissue. Then we also have a swelling or tumor in Latin due to the process of exudation, the transition blood plasma fluid from blood vessels into tissue. And we call that just edema or edema, as you wish. And the main sign that we have is a pain, of course. And I should say that exactly that part of inflammation provoke our patients to do something, you know, because pain is much stable reason for that. Okay, so what is pain? Is irritation of nerve endings in inflamed tissue, which occurs as a result of the action of mechanical and physical chemical factors. Could be mechanical pressure of exudate, acidosis, and hyperosmia, and the action inflammatory mediators. We remember those guys. They have different names. like prostaglandins, histamine, kinins, and much more others. And we have the very interesting sign on inflammation. It goes functionlessa, or impairment of function. So it is resulting from damaged cellular structure, and then the damage of tissue, and then the damage of function. So it all together is connected. Um, if we talk, so those are local sign, and here we have a common sign, an inflammation, and we have here fever, leukocytosis, and increased blood levels, and it's very common in medicine, erythrocyte sedimentation rate, and of course, the worst one is intoxication. So the common signs are determined by the body's overall response to the local inflammatory process. And fever is release of secondary pyrogens by neutrophils and macrophages, among which interleukin-1 plays a leading role. Leukocytosis, an increase in the number of neutrophils per unit volume of blood, and we call that neutrophiliosis, right? And we have a shift of the leukocyte formula to the left. Very common phrase, yes. Increased blood levels of acute phase proteins of inflammation, and we could notice a C-reactive protein, mostly beta globulin, in the blood analysis. So that shows you that you have some problems with inflammation that connected with tissue destruction, especially bone destruction, like we have in chronic periodontitis or chronic osteomyelitis. Increase in the erythrocyte sedimentation rate is due to an increase in the concentration of coarsely dispersed proteins in the blood plasma, which reduce the surface negative change of erythrocytes, as a result of which they easily aggregate and therefore settle faster. And the worst one, it's just my opinion, intoxication, is a toxic effect on the central nervous system of alteration products that we have during that inflammation in tissues, right? So those alteration products, they are entering the blood from the focus of inflammation. And mostly we have normoergic type of body reaction. So it's just normal reaction. It's just average reaction. Is the reaction that we all know as a disease. I mean, you can take any disease, and if you describe it, mostly you describe normoergic reaction. But we have two others, is hyperergic and hypoergic. So hyperergic is more turbulent and fast development of a pathological process. Mostly, we could see that the type in the children's. So, well, when children have some disease, they mostly have hyperergic version of disease. And on the other hand, we have hypoergic. Not sure how to pronounce correctly, but I hope you understand me. So hypoergic is a sluggish, a suppressed reaction, mostly the aged people, okay? Stages of inflammation. We have here, not here, sorry, up, here. We said that inflammation is, as you see here, a typical pathological process. So what makes it typical? It is stages. So it's always same stages. Alteration, exudation, and proliferation. Absolutely same stages in any inflammation. Any. Tooth, periodontium, bone, joint, kidney, brain, heart, uh, everything. So it's always the same stages. Alteration, so damage to cells and extracellular structures, information of inflammatory mediators. You remember that prostaglandin, histamines, and others. The second stage is exudation, is the release of fluid and blood plasma components dissolved in it from blood vessels into the tissue, as well as the migration of leukocytes. And proliferation, finally, is the productive stage of inflammation occurs in several stages that have certain specificities, yes, in different organs and tissues. A neoplasm of a young, we call that granulation tissues, of young connective tissues, followed by epithelialization and scar formation and remodeling. Um, exudate, depending on the characteristic of the cellular and biochemical composition, we are distinguished, as I said, in three types. Mostly in stomatology, in dentistry, we talk about serous and purulent exudate. Of course, there is a fibrinose exudate, but it's mostly with larynx, and that's not our deal. Okay, so serous exudate is almost transparent and characterized by a moderate protein content. You can see here 3 till 5%, mainly albumin, the protein, right? It has low specific gravity. They have some pH within 6, 7. And the sediment contains single segmented granulocytes and exfoliated cells of the serous membranes, and serous exudate is formed during serous inflammation of the mucous and serous membranes. Serous exudate is easily absorbed and leaves to no traces or a slight thinnering of the serous membranes is formed. And purulent exudate, we're gonna skip fibrinose, okay? Purulent exudate contains blood plasma, leukocytes, and purulent bodies, destroyed leukocytes as neutrophils and monocytes. And as you already know, pus or pus in Latin is a viscous and yellowish green substance. Yuck, right? But I'm sure you know that already. Stages of purulent inflammation, we have stage of purulent infiltration and the stage of purulent fusion. So on the stage of purulent infiltration, there is a maximum emigration of leukocytes into the area of inflammation. Leukocytes perform the functional phagocytosis. The cellular mediators of inflammation are formed primarily lysosomal enzymes, which leads to swelling, compaction, redness, and, as we all like, is a pain. Why I say that? It was just sarcasm, okay? The stage of purulent fusion. So leukocytes are destroyed, a large number of lysosomal enzymes are released, which destroy the surrounding tissue, and an abscess or phlegmon is formed. Due to the presence of lysosomal enzymes, the abscess opens outward. Hemorrhagic exudate. ichthyotic exudate and mixed exudate. Also, we could see that in maxillo-facial area. So if we talk about hemorrhagic exudate, is a liquid part of plasma that has left the bloodstream along with erythrocytes and leukocytes. Exudate with blood impurities is formed during inflammation caused by highly virulent microorganisms, influenza viruses, and others. Hemorrhagic exudate is also observed during allergic inflammation. Ichthyotic, I suppose, or ichthyotic, not sure how to pronounce that, exudate develops when it's all from ancient Greek, okay? So it's ancient Greek words that I'm not sure how to pronounce, sorry. Ichthyotic, maybe we need to check it. Just remember what is that, okay? So I'm gonna pronounce like ichthyotic. I like it more. It develops when pathogenic anaerobes participate in the inflammatory process. Inflamed tissues undergo putrefactive decomposition with the formation of fatty gases and dirty green exudate. We have that diagnosis in dentistry, just one diagnosis, where the ichthyotic exudate taken place. It calls the phlegmon of Ludwig, or Janssen Ludwig, or Ludovic, or whenever you pronounce it, okay? So we have just one disease with that. And when you see ichthyotic exudate in a croc croc examination, right? So it's 100% Janssen Ludwig phlegmon. Okay, okay. We're gonna talk about that lately, okay? Not today. Today is just common things about inflammation. Mixed exudate has signs of previous exudates occurs when a secondary infection joins. Very easily to understand. Yeah, of course, we have a few classification of inflammatory diseases, as always, right? But it's just classification that not force you to use any. Of course, we use international classification that has some codes for each disease, okay? That classification is just for your understanding that we have odontogenic, now we have a non-odontogenic, and we have a specific infection. So odontogenic means that our problem, the source of problem, is a tooth. Odontos from ancient Greek is a tooth. And genesis is like where it's come from, okay? And not odontogenic means that not connected with tooth, but still there is infection somewhere. In the skin, in the ear, the pharynx, others, anything. But it is not odontogenic. So that's not our deal. That's not our problem. Okay. And we have a specific infection. What means specific? Specific means that you have a disease and you have some bad guy that provokes that disease. Okay. Exactly this one. So we have actinomycetes, we have a tuberculosis, we have a syphilis, we have other things. So there's a absolutely specific bacteria that provokes that. Another classification, let it be, but still is just for your understanding how it could look. I mean, as you can see here, is the thing that I don't like. It's 5 periodontitis. If you open any manual, any book, I mean the academic book, they don't use that classification. But still, we have those croc question about that, so we have to learn that, like here. So we have a serous periodontitis, purulent periodontitis. As acute, and as a chronic, we have a fibrous, granulating, and granulomatous periodontitis. Whew. Very hard to explain. Okay. But on therapeutical dentistry, you could see those differences and how to distinguish them. What is interesting here is dependence of acute odontogenic process from the causal tooth. And we could see that first molar and third molar are those guys who provoked most problems for us. Okay, why so? Because first molar is the most aged tooth in our mouth. Okay,
Yeah, because
it erupted first,
yeah.
and they had a hard life of living. So that is a problem.
It depends on what you're eating.
Yeah. Not just for eating, like many causes for that. And third molar, always problematic, always. I mean, wisdom tooth is always the problem, mostly. There is a few lucky guys who live without any problems with wisdom tooth, but mostly they provoke many problems, and they situated very far, and there is a lot of debris and people not cleaning them well, so they are very nice source of infection. Source of infection. Um, Two ways of spreading infection into periodontium. We have infraroot and we have marginal. As you can see, it's very easy to understand. Infraroot is with pulpitis and pulp necrosis, and marginal is from the side of the gums through the damaged gum pocket. You never know how it will happen. So depending on the localization of the pathological process in the periodontium, the following are distinguished. We have apical periodontitis, marginal periodontitis, and diffuse periodontitis. Please just percept it as just information. No need to take notes about that, because I mean, of course, in your country, you're gonna use your own classification of periodontitis, and the description in the documents that you fill when you have a patient should be like your Ministry of Health demand from you, you know? So we just like talk about something, some periodontitis. Yeah, not sure how you use that. And here you can see the pathogenesis of periodontitis development. See the problem that came from apex and the problem that came from marginal gum. Clinical manifestation of acute periodontitis, as you can see here, and I repeat, we have two periodontitis according the classification that we use here. It is serous and it is acute purulent. So about serous periodontitis, the involuntary pain to statics are not disturbed, and there are no abnormalities in the gingival mucosa. So there is some sign that you can distinguish the serous periodontitis. And about the purulent periodontitis, we have intense troubling pain with irradiation on the branches of the trigeminal nerve. We have collateral swelling of the gums and enlargement of the submandibular and submental lymph nodes. And of course, by the way, as a common sign of inflammation, And as a result of intoxication that I said before, we have a subfebrile temperature. Okay, and of course, all those things you're gonna repeat on therapeutical dentistry, but still, here we're talking about surgical methods of treatment of treatment of periodontitis, of course. So that's why we have that. That's why we have that in that lecture. And what about a chronic periodontitis? We have three types: it's fibrous, granulating, granulomatose. Okay, let it be. About chronic fibrous periodontitis, we have spine pain when chewing hard food. We have a percussion is positive. If we do the radiological examination, we could notice a wide periodontal gap. But I could say that you could have no complaints at all with fibrous periodontitis. No complaints at all. So it depends of type of the reaction. You remember hyperallergic and hypoallergic. So it depends. It always depends. And chronic granulating periodontitis, we have pain when eating hard and hot food, mucosa of the transitional fold. Is epidemic. We have tooth percussion is positive. Palpation of the gums in the projection of the tooth root is painful. Fistulas on the gums. I hope you know what is fistula. Skin of the face and neck. So fistulas on the gums, or it could be on the skin of the face, or it could be on neck, or it could be in different two different parts. Maybe one on the gums, one on the skin on the face. So it's always depends. And radiologically, if we do X-ray examination, we could see a zone of rarefication with uneven or it's not sure. Is it okay to use that word in English? It's eating ages. It means it looks like someone, you know, eat that on the edge. Is noted in the apical space of the roof. Now we have a chronic granulomatous periodontitis, often asymptomatic. Really, really, really. So patient could not even know that he has that problem. And in most cases, when you treat some tooth, I mean the root canals, and you're doing X-ray examination, and you see on the neighbor tooth that okay, Mr. Someone, you have some problems here, and patient said, I feel nothing about that. It grows by years without any symptoms. And radiologically, we could see a zone of bone thinning with smooth, clear edges. And here, schematically, or how to say that, you can see all those three chronic periodontitis: granulating, fibrous, and granulomatous. I should repeat again. It's not necessary that you use the same classification. It's just for your information to pass all examination here. Okay. Let's move on. Histological structure of root granulomas. Of course, we could talk in any subjects, but here we have a lecture, so we need to do some lecture things. But on practical classes, you can talk about anything. Yeah. So here you can see the clinical picture
Yeah.
of chronic granulated periodontitis. And those things, they are called fistulas. So that is fistula. Fistula is the end of some canal. Through that, our organism just throwing out any problems.
Okay.
So if you see some of that fistula signs, it means that you have some source of infection in the bone. Of course,
Mm.
mostly it is odontogenous infection.
Yes. And that
Um,
occurs
yeah, so it could be look like this. It could be look like this on the palatine
outside.
and even on the chin. Okay, so it could be everywhere. It depends on the tooth. So the tooth is the source of infection. Source. Okay. Yeah, migratory granuloma of the face is the result of periodontitis. It's a chronic periodontitis. So what we need to do, not struggling with that fistulas, we need to remove the source of infection, you know, the
Yes.
source of infection, not the result of infection. And we switch to most interesting thing is a surgical methods of periodontitis treatment. We have a few of them. Not sure if you heard something about everything, but we're gonna see what is this. So we have as a first method is a tooth removal with subsequent curettage of the socket. Very nice treatment, yeah. No tooth, no problem. Yeah, but it's the
Or maybe it's
last,
better to be toothless.
yeah, it's the last thing that you can use. But still, most dentists doing exactly like this.
Yes.
But I'm not recommended to do that.
I,
Then we
I'm
have a root apex resection. Very nice thing actually, and that could save a tooth from descent of the years. Really. Another word for that is apicoectomy, with simultaneous removal of granuloma. Uh, just separated removal of granuloma as it is, without simultaneous removal of granuloma. Then we have a tooth replantation. It means that you have that your own, not your, the patient's tooth, and we replant it on the same place, in the same place, sorry. Of course, cleaned it before replantation. Very interesting thing is hemisection and amputation. So hemisection is removal of the tooth root along with the crown part of the tooth, and amputation is removal of the tooth root with the crown part preserved. And coronary radicular separation, dissection, sorry, of the multi-rooted tooth into parts in the bifurcation area with curettage of the area of the interroot pathological process and subsequent clotting of each fragment with an artificial crown. Here you can see the extracted tooth, exactly the lower molars, because we have two roots, nasal and distal root. So it's lower molar, and we have apical granulomas on the apex. Most cases, 99.9% cases, the granulomas removing with tooth. When you remove within tooth, you're removing granulomas.
it's
It's
attached to
connected. It's connected very, very hard. You saying what?
it's attached to the tooth.
Yeah, it's attached very, very hard.
Mm.
So yeah, mostly it it extracting with it is extracting with
Yeah.
tooth. If we talk about amputation of the apex, we have, of course, some indications for that. Indications, it's very, it could be very different, but you read it here. I have to say that the problem with it could be made by actions of dentist. So be careful with your endodontic treatment. Mm, it's very hard field to practice if as a beginning doctor. As you when you're beginner. Okay, sorry, when you're a beginner, because endodontic treatment requires a lot of instruments, a lot of knowledges, a lot of uh,
Skills of.
skills, and a lot of everything. And when you're doing like mediocre, it's not good. Okay, so then you can have as a result, you can have periodontitis, and then you have to do something with that. Of course, if that your patient and you could do this, and this. I'm not sure about your country if you could be endodontic
Yeah,
doctor
yeah,
and
yeah.
you can be
With the
surgical doctor.
specialist. Yeah, yeah, yeah.
Yeah,
We can
so
be.
it depends. But be careful. So what we need to do? We removing the some apex part of the root through the vestibulum of of oral cavity. So we have to do an incision of soft tissues. Of course, we need to move it.
To
I
have
mean,
access.
not cut it. Just we just move
Yeah,
it.
yeah, yeah.
Okay.
Just to have access. Yeah.
Yeah. And then we doing that bone access to our apex.
Mm.
Of course, we're removing that with some instruments, and we, if it needs, we can do a retrograde filling.
Mm.
I'm gonna show you next pictures, and then you can close those flaps and put some sutures. That's it, no big deal. Mostly apicectomy works for frontal tooth, not for molars. So it's not comfortable to act, okay, to do
Yeah.
that
Mm.
actually, and mostly it's frontal tooth. Um, yeah, so you can see the exactly surgical technique as I tried to explain before. So it's not so big deal actually. It's not so hard to do. And of course the result is very nice. I'm gonna show you some picture of that. And of course, there's a contraindication to apicectomy surgery. You can see it here, but still the it's you who take a decision, okay?
Mm.
Okay. Of course, it depends on many problems and many cases. It depends on your patient and depends on his physiology and depends on the tooth and depends what you're gonna do with that tooth after
Yeah,
that. If you're gonna use it for some prosthetic things or something.
yeah, yeah, yeah.
Okay, types of muco-occipital flaps. Which one you gonna choose? Again, it's your decision. The decision lean on your skills, on your instruments, on your knowledges, you understand that?
Yeah, yeah, yeah. Yeah.
Okay.
Okay.
But what I recommend you is to use a paramarginal flap. Why? Because the triangular flap, as you can see on the A,
Yeah.
it was very common, and I'm sure that it's still common for using.
Mm.
But in that case, you damage the populace between the teeth. There's very, very intimate tissues there. That could be not good as a static result after healing. Okay, so I recommend you to use a paramarginal incision, because in that case you're not touching them, you're not spoil the architecture of those tissues. Okay, it's very important, very important. See the clinical pictures. A paramarginal incision is what I try to explain you why it is very useful, because your margin gums not touched.
Yeah.
It's very important for aesthetic things. Crescent incision, marginal incision of the palate area, no problem, and marginal incision. Cool, cool. Yeah, so again, the resection of the apex. You doing some X-ray, even with good endodontic treatment, as you can see. But you have that problem. Uh-oh, Mr. Someone, you have a huge problem here. But he said, hey, doctor, 3 years ago, you did that endodontic treatment. And you said, okay, that's a huge problem now. Oops. Oops. But absolutely painless. Absolutely no complaints, nothing. Absolutely nothing. It grows very slowly. It grows absolutely asymptomatically. Okay. And then you see that on your X-ray examination. You can see, okay, we have to do that apexectomy. No big deal, actually. That's not so hard to manage. See, we're doing some fenestration. It calls fenestration when you're doing some window in the bone first. So it's like fenestra in Latin, okay? And in Italian, and fenêtre in French, it's the same, okay? So it calls fenestration, and then we removing that and put some sutures, as I said. Yeah, here you can see some attachment to the tip for retrograde filling. As I said, retrograde filling is described in some literature, but I think that nowadays, if you use epoxy resin and gutta perch paints for endodontic treatment, I suppose that you don't need to do any retrograde filling, because it taken a place previously when dentists used most the cement zinc zinc cement for root treatment, and that cement, yeah, so it dissolves in some time. Okay, that zinc cement. So if you use epoxide resin material for root treatment, maybe you can skip the retrograde filling. Some instruments for that, again, recommend you to use Lindema burr if you drilling some bone. So it is absolutely prohibited to drill bone with diamond burrs. Okay, don't do that. Don't do that. It's absolutely prohibited. There is a Lindemann bar, or there is some steel bars with low speed handle piece. Okay, not for turbine. Okay, so the clinical picture: X-ray before and after root apex resection surgery. You can see on the first picture, if the doctor, if the dentist is not very skilled, they could fear of that. Yeah. Oh, that's a huge problem. What am I supposed to do with that? Let's remove that tooth. You don't need to remove the tooth. Even if the problem is much more bigger than the tooth, you still can manage it. And of course, if you want to say a Maserati, another one, a third one Maserati, if you want, of course you can say, okay, we need to remove that and put some implants there. Okay. Yeah. Do you have at least first Maserati?
No, sir. Don't need it.
So, okay, so till you will have your first Maserati, you're gonna put some implants maybe. But remember, that is not good. That's not good because there is an other's way to solve that problem. Okay.
Yeah.
Okay. Another one methods of treatment is tooth replantation, mostly in a children age. You can see the indications and contraindications. But of course, it could be successful if transporting of that tooth was correct. I mean, the place when you had trauma, not you, the patient, of course, and the place when you can do the replantation, of course, that's not the same place. Mostly in kids just playing on some how to say that, some kids places when they just doing everything, all that things, and they have a trauma there, and then you need to transport it. The transport should be a physiological solution. It could be saliva, it could be milk, by the way.
Okay.
You can transport it in the milk.
Yeah.
Or you could transport it in physiological solution. You can buy it in pharmacy.
Okay.
Just for injection. The solution for injection, you know?
Yeah. Okay.
Okay. But if you will transport it in your hand when you're gonna have kids, don't do that. Okay. You need to transport it in some physiological solution. Why? Because we have 3 types of healing of replanted tooth. That depends on how many cells, how many cells are still alive on your periodontium. If you transporting your tooth in your hand, most of them gonna die.
Okay.
And then you will have some osteoid type of healing. But if you transport it correctly, and if you're lucky guy, you're gonna have a periodontal type of healing when the alveolar, periosteum, and periodontal remnants are fully preserved on the root, on the replant. And we have something between the periodontal and an osteoid is a periodontal fibrous when they are partially preserved. So, as I said, you have to do correct things if you want to have a right result. Okay, let's move on. Hemisection and amputation. Very interesting things. I tried. Yeah, I just tried once. Yeah, I tried once hemisection, and I saw few times, perhaps it was just 2 times, I saw the amputation, result of amputation. So hemisection is removal of the root along with the adjacent crown part of the tooth, and amputation is removal of the entire root while preserving crown part of the tooth. So of course there is indication again. Again, there is indication. And again, I could say you, yes, of course. So all those methods of surgical treatment, periodontitis, was invented, developed, and acted in those years when the implantation, with tooth implantation, will not so widely use. Okay. Of course, today, I mean, even exactly today, we don't need all those things. We have implants, and we know a third Maserati, of course. So we can do that absolutely with no problems. And it's very interesting, at least to try a few times and see the result. In the case, if the patient is very okay to, let's say, to play that game, okay? Okay. But if you want to have 100% result, prognostically clear result, of course, is recommended to do some implantation. Let's move on. So contraindication, of course, we have also for section and amputation. As you can see, the significant defect of the bone tissue of the target, the tooth has no functional and static value, the presence of the first root, and acute inflammation of the oral mucosa and impossible root canals of teeth suspected preservation. Here you can see the schematic picture of amputation. Mostly, if we talk about amputation, we talk about the buccal canal of upper molars. It could be medial buccal or distal buccal root of upper molars, because there is a free root, as you remember. Mostly never removing palating root because it's not so easy to access and it's pointless. Okay, so mostly it's just buccal, not buccal, buccal, sorry, buccal root, mesial buccal or distal buccal. Okay, and hemisection. Hemisection of the tooth. You can see the clinical case. We have some crown, and we have very actually nice endodontic treatment. No sign of any problems, but in few years, as you can see, we have some periodontitis. Why we have that? Lot of reasons. It could be not good at endodontic treatment. It could be not good, not right irrigation of some endodontic solution. So you didn't kill everything there, and you just fill that with some filling. Not good. You can skip one of the canal. For example, here on the mesial root, it mostly should be two canals, but I see it's just one. But it's just an X-ray. I can't say anything more.
Yeah, it's
It
only
could be just two like this, and when you oh, there's a two,
yeah.
but as I told you before. Okay.
Yeah.
And what doctor did? We're removing the crown, of course, and we just separate the mesial root, and the socket will heal with normal bone. Everything's gonna be okay there. And then we just use that distal root with that coronal part, just as a premolar. And use that premolar as here as for the prosthodontic thing. Yeah. Problem with sixth tooth, problem with first molar. See here, it is hardly destroyed. We're removing mesial root, And we doing that endodontic treatment of that root. And then we put some crown on that. And as you see on the X-ray, in the last X-ray, we we took a fifth tooth for that prosthetic. Mm, it's very discussional, you know, for me and for everyone. Of course, that's the way we deal with that problem. Why it is discussional if that word exists, you know? So it could be a lot of discussion on that subject, okay?
Yeah.
Why is discussional? Because why we destroyed a premolar for that? It was a normal premolar, as we can see here, but we did a lot of work for that. The result in many years, we cannot predict exactly right result. And that's why I said before that, of course, it's very individual in any cases. If we talk about 82, I mean, the year 82, you know, it was very common. But nowadays, if you're doing that, you look very weird, you know?
Yes.
Because,
Missing
okay,
half of
what
it.
are you doing and why did you do that? You just remove the first molar, not not touching a premolar, and you just put implant. That's it. But 40 years ago, even 30 years ago, even 20 years ago, that was not so easy, you know, not so cheap. Yeah, another clinical case. As you can see, the same problem. We have molar, we have periodontal problems. We remove, in that case, we remove a distal, distal root. And here, as you can see, they did a metal crown, and they not touched
The second
the
part,
second
molar.
molar. They just did the occlusional flap, like
Mm,
they just
yeah.
on the second molar. Okay, but still, it's first molar. And as you can see, very, very, very small root. Um, the first molar is very important tooth. First molar taking a lot of pressure during chewing. And if that is a man, I'm not sure, I don't know. So if that is a man, it was not good reason to do that prosthetic. That's why I said it's very, very individual. It's very individual. Of course, again, in that case, would be very predictable and very, I mean, reasonable, sorry.
Reasonable.
Would put the implant, but still, we talk not about implantation this lecture, we talk about surgical methods of periodontitis treatment. Another one, almost the same. Here, as you can see, also they took a second premolar on the prosthetic. Okay, not good, but okay. Coronary radical separation, another way to treat. Please just do some distinguish in your head, okay? Between hemisection, amputation, and coronary radical separation.
Okay.
Amputation, we just remove just tooth with the crown still there. Hemisection, we remove root with the crown part. And coronary radicular separation, we don't remove anything. We just cutting it on the half division. Yeah, I'm gonna show you how it looks. The division of the tooth into two parts, as you can see, in the bifurcation area, with sequent, careful smoothing of the overhanging edges. There is indication, of course, mostly when we have a problem in the bifurcation area. That's a huge problem. And we have contraindication, of course. But again, always you can put implant. Okay, coronary radicular separation procedure. As you can see here, we have some problem in bifurcation. And first molar is really huge problem. Why? Because there's a place that's very bad for treat. I mean, you can do almost nothing with that. There's always some infection there. It's always some inflammation there. It's always some problems there in that bifurcation area. And most of cases, people just removing it. So that tooth is not any useful because it's always some problems with it, sorry. And what we do, we just cutting it at the half, not removing anything. In some literature, it calls premolarization. So you're doing some premolars from molar, premolarization. Okay. Yeah, but it's just for information. Acute inflammatory processes of soft tissues of maxillo-facial area. I have to say that we have a separate lecture for that on the spring semester. What you need to understand here, that abscess is a localized and phlegmon is a diffuse. It's the main reason how to distinguish them. Phlegmon is acute diffuse inflammation of the subcutaneous, intermuscular, and interfacial tissue, facial maybe, characterized by a tendency to rapid spread. The process is diffuse from the very beginning. Inflammatory phenomena increase so rapidly that the formation of the demarcation zone is the term that used in phlegmons, is delayed, and the delimitation of the lesion is impossible. The ratio maybe, as it sounds more Latin, to abscesses to phlegmons is 4:1. Primary and secondary phlegmons are encountered in clinical practice, and secondary phlegmons are the most often accompanied by osteomyelitis of the bones, and we call that osteophlegmon, or other complication of purulent lymphadenitis. Different source of infection. As in the other areas, it could be odontogenic. Of course, it's our tooth or teeth, but mostly it's one tooth. Introlysis, it means from the bone, right? Gingival, mucostomatogenic, salivary, tonsillopharyngeal, rhinogenic, and otogenic. Otogenic means from the ears.
Yeah.
Others is from ancient Greek, is the ear. Aetiology of those problems, I mean, I guess it's not so useful for you. Okay, let's move on here. Yes. About diagnosis, not sure if you as a dentist chirurgien, you're doing that in your country. Not sure. I'm sure about phlegmons, 100% no, but not sure about abscess in maxillofacial area. I mean, in dental office. And you, as a dentist, can you do that dissection or incisions?
No. We don't have the right to touch it.
Yeah, but still we need to talk about that. So
Yeah,
you
yeah.
have to diagnose of odontogenic inflammatory processes. And there is a 4 main local features. Let's talk about that. First sign is a causal tooth. We call that causal tooth because that tooth was exactly the cause or the
The
source
onset, yeah.
of our infection. So it is localized in the periapical or marginal tissues around the tooth. Mostly, as we had before, it's first or third molars, but not always. A second sign is a sign of inflammatory infiltrate of the soft tissues of the maxillo-facial region, expressed in superficial inflammatory processes and less pronounced in deep ones, but still it exists. But you don't see that as the superficial, yeah. Visual manifestation of infiltration is a facial asymmetry due to soft tissue swelling. Have to understand that visual manifestation as facial asymmetry doesn't mean that you have abscess or phlegmon. It could be just inflammation of soft tissues like inflammatory infiltrate. Inflammatory infiltrate could be just as itself, or it could be as a part of this, or mostly it is a sign of periosteitis. So periosteitis is very common thing when you have problem between periosteum and the bone. It's very easy to manage. And of course, you can do that in your dental office, I suppose. So it's not abscess, not a phlegmon, it's periosteitis. It's different things. It's still pus, still near the bone, but it's not the same. Third sign, the sign of motor impairment function of the mandible. Limited painful mouth opening, impaired lateral movements, and forward protrusion, of the mandible. And fourth sign, a sign of difficulty and painful swallowing. The decompression of the lateral walls of the pharynx formed by inflammatory infiltrate, as here, the same thing. Clinical manifestation of anaerobic infection. Here we are with our ichthyotic exudate. Anaerobic infection. Characterized by particular severity and the lack of positive dynamics of the process, even with sufficient drainage of the inflammatory focus.